Hi guys, hope you had an awesome weekend. Week number 7, and I'm going to start with by giving you some feedback, and then I'm going to move really quickly what we have this week because chapter 9 is a long chapter, pretty technical, and I'm going to try to cover as much as possible and not um, have a very long video. Okay. So very satisfied by your performance. LO16 average score 90%, LO17 98%, and LO18 92%. The only item I need to give feedback is one item from LO18. However, it's an item that I'm really interested in you understanding it. So it's I'm not very happy that that was the item that most of you didn't get right. So it was one about the risk factors and how many, right? So the right answer is 3, as you all know. You got the feedback. The, 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 the thing now is why? Why is that? So please go to chapter 11, towards the end of the chapter, and look over there, right before the case study, and then read the case study and try then to figure out what was going on with the item from LO18. It is a practical problem, which means you need to be able to understand the theory and apply it. Okay, try to figure out why these are 3 risk factors, not 2, no 4. Okay, just go over that item. That's pretty important. Do me that favor. Okay, so this week, what you have to submit is 3 LOs, 19, 20, 21. As I already said, we're covering chapter 19. Still office hours tomorrow from 8 to 12:30. No synchronous meeting. I would like you to at least start figuring out your group for your PDO and the case study. Okay, start reading it a little bit and know what to expect, who are the people you need to visit with, who is doing what, how you'd like to go with it, okay? Again, if you have any questions about your PDO or anything else, log on tomorrow during office hours. The link for the Zoom, for that Zoom meeting will be included in this email. Okay, yeah, I have my notes here. I don't see anything else. I'll keep them here so it's up as we go. Okay, so I'm gonna go ahead and share my screen. This is our Moodle site, okay? This is where we are. I'm covering chapter 9, and these are the 3 LOs you have for Sunday. Yeah, that's pretty much it. We have time for your PDO, but I would like to start thinking about it, okay? Because the FLO is going to come pretty quickly after the PDO, I mean. All right, I'm going to stop sharing this. I'm going to start sharing our slideshow again. Long chapter, 80-something slides. I'll do my best. Pretty technical. I'm going to go into a lot of detail, not all of them though, okay? So let's start. And again, I will try to keep it as short as possible, okay? So today we're going to talk about exercise prescription in very specific patients who have cardiac disease, peripheral disease, cerebrovascular disease, pulmonary disease at the very end, okay? Again, a lot of terminology. Hopefully you remember enough from PED214. If not, revisit and spend some time, not just to read, but to study the chapter, okay? Please. All right, so cardiac diseases, very common, very prevalent. people who participate in regular exercise and change their lifestyle will benefit from those two. Okay. Cardiac rehabilitation. Cardiac rehabilitation, of course, will happen. In our term here, we'll see it as inpatient, right? Which is kind of short in the hospital right after an event, including education as well. Outpatient, longer, usually after inpatient, if we have inpatient. Okay. Yeah, cardiac rehabilitation pretty much is about those two things that we already talked about and that they're beneficial, regular exercise and lifestyle change. Okay. All right, these are terms you should know. I'm not going to go over them. They're right there with their explanations. Okay. For example, in a little bit towards the end, I would say, after the middle of this slideshow, definitely, we're going to talk about PED, which is right at the bottom. You need to understand what PED is. What is also a cerebrovascular disease? We're going to talk about cerebrovascular events, right? Strokes. We have covered this before. So go over these if you don't remember what they are. The definitions are right there. If you have an issue with terms in the definition, look them up, study, comprehend. All right. Inpatient. Let's start with inpatient cardiac rehabilitation programs. We need to focus on these specifics. What's the current clinical assessment, mobilization status, how mobile they are, identification and provision of information that has to do with the risk factors, and which ones we can modify from those, right? In example, risk factor that we can modify is smoking. Risk factor that we cannot modify is that your father, their father, my father, whoever's father, the patient's father died at 45 from a cardiac event, okay? And when you discharge them, when they will get discharged, to have some kind of planning about what's going to happen when you go home, okay? Okay, assessment is important. Now we have the ambulatory sessions, okay? Important, but there are some conditions for them to happen and some conditions that if they happen, we need to stop. Okay, we want them to do it, we want them to walk around, but we need to be careful. We're talking again about we're in the hospital and we're right after an event, okay? Risk stratified has to do with what I just covered in the item that most of you didn't get right. That's what I'm telling you, this is important, especially if you ever end up working in a facility as an exercise physiologist that has to do with cardiac rehabilitation, okay? When can they do it? When there's no new or recurrent chest pain the previous 8 hours, stable or falling creatine kinase. So here we have an enzyme that has to do with muscle damage. So after an event, if CK is high, means that the muscle of the heart is damaged. That's not good. Troponin, we have a protein which is associated with heart muscle. It shouldn't be in the blood. We find in the blood, again, it means that there is damage in the muscle of the heart, cardiac muscle. We don't want that. That's why we need stable or falling. No indication of decompensated heart failure. This is a clinical syndrome. So we had an event, and there was a structural change. That's what I was looking for in the heart, so it doesn't function well. Rhythm stable. Okay. Adverse response to inpatient leading to exercise discontinuation, which means if this happens, we stop. DBP, SBP, arrhythmias. The heart blocks, it has to do with the electrical signal. I don't want you to know a lot of details. Just know the third is more severe than second, more severe than the first degree. Okay. Signs of exercise intolerance, including angina. Okay. Dyspnea. Okay. You know, ischemia. You should know all these things, right? Okay. I'll go a little bit closer. Indications and contraindications. Medically stable, okay, stable angina. Stable angina is much better than unstable angina. Okay, stable, you see now it's an indication. Unstable is contraindication. Unstable is a situation that's why it's called contraindication. Okay. Coronary artery bypass graft surgery is when we bypass an area that is blocked or have restricted blood flow by going the other way. PTCA, when we go to our femoral what's what I'm looking for, artery, and we throw in dye, and the dye goes into our heart, and then through X-ray we can see which areas are working or not, right? Dysfunction cardiomyopathy in general could lead to heart failure. Okay, heart transplantation, we'll talk about that. Okay, surgery, PED, we just talked about it. Okay, unstable angina, uncontrolled hypertension, orthostatic blood pressure drop. So when you stand, boom, you have hypertension, pretty much. Stenosis, we talked about aortic stenosis, arrhythmias, tachycardias. You should know what all these things are. Uncompensated heart failure, third degree block, pericarditis, myocarditis. We talked about inflammation, right? Pericardium and myocardium, embolism, which has to do is, you see, pulmonary or systemic. Pulmonary, so in the circulation system between the heart and the lungs. Systemic is the rest. Okay. I hope you know this. Acute thrombophlebitis. So it's a thrombus in the vein. Aortic dissection, acute systemic illness, uncontrolled diabetes, severe orthopedic condition. Okay, you know that. Now, this is for inpatient. So how do you prescribe while they were talking about inpatient cardiac rehabilitation? You see, first of all, I want to make a comment, and I'll stop in the things that I need to stop. Other things I'll be like, you can read by yourselves. Okay. Here, what I want you to see is that there's no resistance training, right? Okay. What else? You see, we have flexibility. If you are all the way down, if you are bed bound, somebody else can do it for you. What do I want to say? Intensity. Sitting or standing HRS plus 20 for patients with an MI, and plus 30 for patients recovering from heart surgery. Okay, you read all this. There are different things for different patients that have what we acquire in cardiac rehabilitation. Intermittent walking, attempt to achieve a 2-to-1 exercise rest ratio. Progress to 10 to 15 minutes. Okay. All right. When they're getting discharged, as we talked about, give them specific instructions of what they do. If they need to be supervised, of course. Until evaluated or supervised, the upper limit of heart rate or RPE noted during exercise should not exceed those levels observed during the inpatient program. Okay, so don't go. Don't do more. Don't increase intensity. Okay. Cancel eligible patients from regard to participate in clinical supervised. Okay. Outpatient. So lately they're trying to discharge people really fast, and sometimes there's no time for inpatient, or for that other reasons they don't do it, so they go straight to outpatient cardiac rehabilitation. So we have these assessments: history, physical examination, ECG, severity factors, which is exactly, again, the severity risk factors is the item that most of you didn't get right, carrying medications. Okay. Now this outpatient, for example, is the class 1 recommendation. You'll see throughout this chapter. We have a combination of the class with the level, right? You see the classes and you see the level. The best is the higher class. Class 1 is the highest in level towards A. Okay, so 1A is the best. Okay. Goals. Everything is pretty much expected. I want to just stop a little bit at the last one, which is provide patient and spouse, partner, family education to optimize secondary prevention, because now we are into secondary prevention, right? I hope you understand what's the difference between primary and secondary. We've covered it. If you don't, look it up. Spend time, study. Components of outpatient. Nothing you can read by yourselves. Pre-exercise assessment. Performed before, during, and after each session. Okay, heart rate, BP, body weight, symptoms, exercise intolerance, or symptoms of any kind of clinical status that have to do with physical activity. Change in medication have to be taken into consideration. ECG, surveillance if we can. Yes, okay. Exercise testing. 3 weeks. So for exercise testing early 3 weeks or later after hospital discharge is useful. Okay. We see class 1 recommendation, class 2 recommendation. That's exactly the table we talked about. Okay, nothing too fancy here. Okay, so here we are in the outpatient. I want you to notice that we have resistance training. Okay, and you'll see that's a little bit more advanced than the other one. Before, a little bit of higher intensity, definitely more time. Resistance exercise, resistance training for sure. That's something to underline. Yeah, that's pretty much it. The rest is are self-explanatory. At least 10 minutes each. If they can, less than 10 minutes, okay. Increase 1 to 5 minutes per session. And there's something, if there are things that they can do by themselves, encourage them to do more by themselves. The only thing I want to say here is if there is an ischemic threshold, which means above a threshold, we have ischemia. I hope you know what ischemia is by now. Please, if you don't, look it up. You don't have to push it up to that level, right? So you work out at a level which is lower. You see here that we go minimum of 10 beats per minute below that, because we don't want to produce, we don't want to put the patient in danger. We want to avoid ischemia. That's not the point of this, right? If we don't know HRRP is useful, take the prescribed medications. If they have it, change the beta blocker because beta blocker will decrease the blood pressure, right? And the heart rate. You need to test it in a way, so we'll have to be careful. Anytime. Yeah, whenever they have less symptoms, it's the best. Okay. Volume depletion is bad, hypovolemia, right? We want to avoid that for sure. So we need to be some medicine, some drugs that help with cardiac rehabilitation are diuretics. So they may be hypovolemic. So we need to know that. Hypokalemia, we know that. Orthostatic hypotension, we covered that just like 5 minutes ago. warm up, cool down, dynamic static stretching. Okay. Now, this is something I want you to remember. You hear about cardiac rehabilitation, then you hear about HIIT training. Would you prescribe HIIT? Well, you should. Okay, you should. I mean, if it's safe, you should, because it has been proven very efficient and safe, of course, with these patients. So have that in mind. Again, use your certification. Make sure you know that. Associated factors to consider when guiding those exercising cardiac rehabilitation include pre-morbid, so activity level. So if I was very active or not active at all before the event, that plays a role when you prescribe exercise, right? Vocational or avocational goals and requirements. And of course, their goals in general. Resistance training volume can be increased in 2 to 10% increments. Avoid breath holding, okay, for the reasons we have covered in the past. ECG, I don't want you to know this. I want you to know that it is helpful. Right, we're not going to do ECG, but at least know that in these kind of environments, it would be helpful to have that kind of information. Okay. We may not be able to do a pre-exercise test. Okay, pre-participation exercise test. I'm sorry. Okay. Lifestyle. So we need to encourage them to exercise. You see, we can measure that through calories per week. But also, except for what they do with us or what we prescribe, in general, we want them to go back to what they were doing before. So whatever kind of physical activity they can do, it's great. The Bethesda conference is the American College of Cardiology. It's about, of course, cardiac rehabilitation. Nothing for you to know that. That's a conference now, though, that came out with a lot of position statements, and a lot of times when we talk about cardiac rehabilitation, we use that conference. So just to know, pedometers, of course, they can use. Okay, nice. Let's go to heart failure. All right. So here we're going to talk about chronic heart failure, occasional dyspnea, and fatigue. Based on systolic dysfunction, you see that's R, and diastolic, you see that P. Okay, most of the things we're going to talk about is about HFREF. Okay, we're talking about the systolic dysfunction. Valuable adjunct. Okay, compared to age-matched healthy individuals, patients with heart failure, that is based on the systolic dysfunction, exhibit a lower peak heart rate, peak stroke volume, and peak cardiac output. Okay, evaluation, maladies. Histochemistry in general is when we take a sample and microscope and we see take it under the microscope. That's how we do this. So this is how we can see the muscle, skeletal muscle. Okay. Exercise tolerance is reduced. That's something we should know. Okay. All right. Let's go to the recommendations. Let me see if I see anything fancy. PNF, nothing in flexibility. 40% of 1 RM you begin, and then 50% gradually up to 70%, 2 sets of 10 to 15. Machines better for balance. Treadmill or free walking up to 30 minutes, and then if we go, I can go up to 60 minutes. And intensity wise, when we talk about aerobic, set intensity between 60 to 80% of HRR. If you don't have data, of course, you go with RP. Okay. Heat again is beneficial. Increase duration and frequency before intensity. This is sad. Less than half are compliant. It's not a surprise for the people who know what's going on, but it's a sad number because they don't do what they need to do after an event. Okay? Or people who actually have heart failure, have chronic heart failure. Their heart is just failing, and they still choose not to do what they're supposed to do. Okay? Remember, barriers to try to help them out with any kind of logistics you could, and we've talked about that in 212 as well. We're going to talk about that in the last chapter of this book, how we can help people with the barriers of exercise. Left ventricular assist device, VAD. Nothing too fancy here. All right, sternotomy. Sternotomy means, and you can go see some pictures. Some pictures may be a little bit too much to see. You know, their sternum is right here, so they open this up in order to go in. Okay, very invasive, extremely invasive, very painful when you wake up. It's a very technical procedure, and of course, right now I'm just talking about the sternotomy. Right, I'm not even talking about what they're going to do, but for this to close back up, it's not easy. We need to be careful. It takes time. It's very technical. Okay. Okay. That's how we can reach the heart and for replacement or transplant. 8 to 10 weeks, sternal instability, up to 16% of the cases. Sternal wires are used to close the sternum. You can check it out and see some pictures. Restricted range of motion, especially in the upper body, as you understand, you don't want this to open up. Restriction of upper body activities, I think it makes sense. 5 to 6 weeks after discharge, most patients have to have returned to pain-free, unloaded. Unloaded, that's the important part here, the keyword. Okay, certain rhythm unloaded and low load upper limb activities while cardiac rehabilitation should be encouraged. Okay, pacemaker. We're going to talk about pacemaker, and we're also going to talk about the defibrillator, the ICD, inflatable cardiovascular defibrillator, which is something very interesting. If you don't know what it is, I think you'll find it interesting. So, pacemakers, why? To restore an optimal heart rate at rest and during exercise, synchronize atrial and ventricular filling and contraction in the setting of abnormal rhythms, and synchronize right and left ventricular contraction in the setting of LBBB. Okay, we talked about those blocks. What else? Okay, this is important. So we have different types of pacemakers. Okay, we have one chamber and 2 chambers. We have the rate responsive, which they try to match level of physical activity, and the single chamber is the right atrium or ventricle. The dual is the right atrium and ventricle, and the cardiac resynchronization therapy pacemakers is the left atrium, the right atrium, plus coronary sinus. Okay, which is I don't want to go there, but I can go there. The sixth sinus syndrome is when the 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 pacemaker that we have in our heart pretty much is not working. Okay, that's what's called sixth sinus syndrome. All right. This is also important. We have 4 letters. First letter, which chamber is paced? So so the pacemaker is going to take an action. So where this action is going to take place? Sensed, second letter is where is it going to sense it? Sense something so it can act. Okay, the act part is the paced. Third letter, pacemaker response. It's gonna trigger, it's gonna inhibit, or it can do both. And the fourth one again has to do with the rate response. As we said, it detects movement and it's trying to mask the level of physical activity, right? So if you see a pacemaker with those 4 letters, you know it's one of them. What it's one of them means exactly. Program pacemaking modes, HR limits, and ICD, the inflatable cardiovascular defibrillator, which again, it has some algorithms. What ICD does, it's trying to fix if it senses an abnormality, it's trying to fix it. If it can't fix it, it gives you a little bit of shock. Imagine that, okay? To kind of reset the rhythm. So we should know that before we do any kind of training. Okay. When ICD is present, we're not trying to make it go off. Okay, so we should be below the threshold. Okay, I hope that makes sense. Okay. Now, cardiac transplantation. We have here end stage heart failure. And the prognosis is that they're not going to survive more than a year. Or it's poor for a 1 year survival prognosis. So then they need to look for a new heart. Okay, 4,000 procedures, and 4 or 5, they survive 3 years later. VO2 peak after transplantation compared to before, okay, that's important, not compared to somebody else, then before and after, may improve up to 30%. All right, so when you get a new heart, it's not exactly, it doesn't exactly work as your old heart in terms of neural connections, okay? So PQ can be reduced 20 to 35% than compared to how much you have if you were healthy and it was your own heart. And the abnormalities that you used to have, they're not going to go away just because you got a new heart. With the muscle, I mean, that is not the muscle of the heart, the cardiac muscle. Compared to age-matched healthy individuals, age arrest is often elevated. Your heart is not working very well, so it has to work harder. It's not very efficient. HR response during an acute bout of exercise and at peak is attenuated. It doesn't work well, slowly. Recovery is slower again, same reason. You can see the parasympathetic innervation. So the nervous system is not connected exactly as it was supposed to be because you got a new heart. Okay, it's not going to be perfect. BP often elevated. Nothing that you cannot figure out by yourselves here. All right. 3 to 5 days per week for aerobic, 1 to 2 non-consecutive resistance, 2 to 3 for flexibility or more. RP we're using here for Intensity, why? Because we just said that the heart rate is off. Okay, I want you to read in between the lines, please. 40% of 1 RM up to 70% of 1 RM, 15 to 20 minutes, and slowly go even higher than that. Yep. All right, special considerations that we have. Okay, immunosuppression therapy. All right, our immune system, we're trying to kind of deactivate our immune system because we don't want it to reject the new heart. By making our immune system to work less sufficiently, we may have other issues, as you can see. Bone loss, diabetes mellitus, and so on and so forth. But that's the thing, because you can live with bone loss. You're going to live without a heart. Okay, so that's a way to make sure our body accepts it. So you may probably find this interesting. Again, you have sternotomy. We talked about sternotomy and what that means in terms of activities. Okay, PAD. PAD is explained in the very first box. Hopefully you studied that and you know what it is. Coronary artery disease, atherosclerotic plaque, significant stenosis, limitations of vasodilation. Okay, I hope this is not Greek to you. Okay, reduction of blood flow to regions distal to the area of occlusion. Okay, reduction of blood flow means less oxygen supply, which affects those areas. Okay, ABI, ankle brachial pressure index is important here for identifying signs and symptoms. Okay, you see CV risk reduction, exercise training, pharmacological therapy, and peripheral revascularization, if you have to, are examples of treatments. You don't have to remember that. Just remember that stage 1 is better than stage 4. Gangrene means that the tissue is dying, so we'll have to cut it off. Okay, we're talking about really bad situation if you're stage 4. Supine, resting ABI, post-exercise ABI. You'll have to remember that. Milliliters of mercury. Okay. Is to be performed to determine functional capacity, exercise limitation, time of onset of claudication pain. Here we have a huge issue with intermittent claudication, right? As you understand, that's a huge thing for these people, right? Excuse me. So the time of onset of that, it's important to determine. Okay. I'll go a little bit closer. Say things about frequency, higher intensities, as you can see, compared to what we saw with heart disease. Of course, more time, more sets, weight bearing, which is important. We want them. The thing is here is that double-edged sword. We want them to bear the weight, but that creates issues. So we need to be mindful. So we want those weight-bearing exercises as much as they can, maybe the rest, and then they go back to it. So we want them to do that as much as they can. If they cannot, let them bike, let them swing, okay? Accumulating only 15. Probably try to go higher, cycling or not waiting when they cannot, especially if you want to save up the pain in a way and just they can let them warm up so you can just make them walk or something probably more painful later on. Not determined. Cold environment is not good, probably bad. Okay, let's talk about stroke. We are at 41 minutes. Okay, I'll try to finish before 60 minutes. All right, cerebrovascular event, cerebrovascular accident, stroke. When blood flow to a region of the brain is obstructed, brain function deteriorates quickly and leads to neuronal or neuronal, how you want to pronounce it, depending on which side of the Atlantic Ocean you are, cell death. Okay? This is not good. It can create a ton of issues. In general, what happens here? There's no blood flow, there's no oxygen, cells die. That's it. Why do we have that blood flow restriction? It can be ischemic, meaning that will have a thrombus, right? Or we can have liquids of blood. Most of the cases are ischemic. With blood flow restriction, there's a clot. Something is going on. Okay, that's the reason. So if something is going on, then you get a stroke. Again, we explain the whole process, right? No blood, no oxygen, cells die. You can read it by yourselves. Avoid Valsalva maneuver, slow speed, of course. Attentive of how they feel. Supervision, instruction. There may be some local muscle and general fatigue. Okay, and in general, as we're in this section, people wanna go back to work. We need to figure out what that work is. Which are the repetitive movements? Are they standing? Are they sitting? What are they doing? Construction, office, what's going on? We need to figure that out and try to help them by prescribing exercise, safe and effective exercise, to go back to work as soon as possible. Okay? That's the assessments we're doing in this exercise prescription. Okay. Pulmonary diseases. Who cares? We care. Why? Chronic pulmonary diseases are significant causes of morbidity and mortality. Please tell me that you know the difference between morbidity and mortality. There's a strong evidence that pulmonary rehabilitation improves exercise tolerance, reduces symptoms, and improves QOL. All right. We have COPD, we have restrictive pulmonary disease, we have pulmonary artery hypertension, we have lung cancer. All right, obstructive. It means that there is an issue with the airflow. Okay, in all these four cases, you'll see the definition right after and then some examples. Obstructive, I definitely want you to remember the difference between obstructive and restrictive. Restrictive is we cannot expand and just take all the quantity of the air we would take or we should take in. Okay, so you see there that it says interfere with normal lung expansion. That's obstructive. Restrictive. Obstructive is when we have an issue with an airflow. We can take all the air out or in. Okay, you see examples up there. Classic example is asthma. We're going to talk about asthma. Pulmonary fibrosis, maybe you've heard about that. And then we have PAH, pulmonary artery hypertension, increased blood pressure in the pulmonary artery due to narrowing, blockage, or distraction, and lung cancer. Okay, all right. Asthma, chronic inflammatory disorder, reversible. We have exercise-induced asthma in a way. Okay, so we need to be careful. Assessment, okay. Inhale bronchodilator, we need to know that. Motor-driven treadmill. Oxyhemoglobin saturation by non-invasive methods, right? The thing that they put when you go to the hospital. Good, right? Hope you remember these things. Dry air is not good. Cold air is not good either. Cold and dry is a very bad combination in general. Saturation less than 80%. Okay, 6-minute walking test, something that we should use. Cool. Frequency, nothing different. You see the 40 to 59%. Moderate intensity, right? That means moderate intensity. 30, 40 minutes, aerobic activities. Okay, nothing. Strength is nothing too fancy here. Wide variability in the ATR max, so we need to be careful. When they have exacerbation of their asthma, we shouldn't try to push them during those days or times of the day. Use bronchodilators if they are necessary. Corticosteroids. They reduce inflammation and swelling. Okay, that's why we take them if we have asthma. However, we may lose some muscle, so we need to be careful. Okay, IMT. We're going to talk about an IMT until the end of this. I just have about 10 more minutes, but we're not sure that you're working with people with asthma. COPD, most likely, we're going to talk about COPD in a little bit. With asthma, training of the inspiratory muscles, even if you're wearing that mask that people used to wear, not now, that mask, the mask that trains your lungs, for example, right? There are other ways to do it as well, but it hasn't been proven beneficial for asthma. Non-coordinated pull, yes, right after working out or exercising or any kind of physical activity. You have to be mindful. All right. And then COPD, fourth leading cause of death and major cause of chronic morbidity, preventable and treatable. Okay. Gases, tobacco. All right. Dyspnea, I hope you know what that is. Chronic cough, sputum production. Okay. Emphysema. And then we have the gold criteria. I hope you remember the FEV1, which is how much air you can breathe out in the very first second, and FVC is how much air you can breathe with one. As we're exhaling, how much air you can move out of your lungs, the whole breath flow. The FEV1 .0 is the very first second, which is very important. So we have the ratio, and then we'll have the percentage. I think I'm going to skip a lot of this. Partial pressure of oxygen, okay, and arterial oxygen saturation could be useful. 6-minute walking tests, okay. Less than 80% again for the oxygen saturation. Arterial oxygen saturation could be helpful to stop the testing. We don't have a very specific dyspnea scale, but if we take the CR, the RP, which is the modified RP, the 0 to 10, we can use this one. Okay. CR10. Okay. Again, we talked about that. Okay, nothing too important. You can read that. These are not extremely important. Also, you can they're very easy to understand. So I'm not gonna spend a lot of time here. Okay. Here, as I said before, IMT may prove useful. Those unable to participate in exercise training. So for COPD, maybe if they cannot do the exercise training, maybe they can do this training of the muscles, right? Inspiratory muscles. What are the guidelines for IMT? Of course, some numbers. Okay. Don't push them when the symptoms are very obvious and people are suffering. And here we have cystic fibrosis, lung transplantation, pulmonary artery hypertension, and interstitial lung disease. So these are other pulmonary diseases than COPD that we can help with exercise training, but there's less evidence. So I think that's the last one. Yeah, that's the last thing for tonight. I did pretty well. I think 53 minutes. I hope it would go way more. Again, it's not an easy chapter, so please take some time and study and understand and make side notes and whatever you need to do. Okay. Hello, 19, 2021. Tomorrow's office hours. I hope to see you tomorrow. In the meantime, lift intentional, not habitual. Bye, guys.